Hello, everyone. Thank you so much for joining today's session and welcome everyone to First Aid AMC MCQ. For those of you who don't know us, I'm Dr. Arshan. I'm one of the tutor of First Aid AMC MCQ. And for your MCQ, I will be the tutor for the whole 5-month session. And just to give you some idea about myself, I'm working in Australia for a couple of years now. I'm working as a GP in here, and I have a lot of experience in teaching, and I haven't ever heard anyone that who haven't liked my teaching experience. So I hope you guys will enjoy our session. And also some of you guys maybe heard about us that we started our last session about 5 months ago, and we are on the finishing of that session on this month. And all the guys have loved the session, and they have, I think, benefited from our course a lot. And we hope that we'll do a lot of good results in the next year or this year at the last, like November, or yeah, most likely in November. So today's session is mainly on psychiatry. It's more about the basics today. Usually when I take the class, I make the session in a way so that we can integrate all the things together, so that we know that if we are doing the theory today, then with the theory we will do some questions also, but we keep just in total one class, sometimes more than one class, for question solvation. The question solvation usually includes, like, if I do the psychiatry today, the next session we will be doing the psychiatry question, so that you guys know that if you are doing some theories, they are for a particular reason, and then you will be able to integrate the theory into the questions. That's the basic of learning mainly, and you should also try to do that. Before I go into more about psychiatry, I just want you to give an idea about how AMC MCQ usually like goes with their exam. The AMC MCQ exam, the format is pretty clear. So it's a 150 question, and it's single best answer question out of 5. Among 150 question, you will get 120 question which will be totally scored, and 30 questions will be pilot. The trick for this thing is that, like, you will not know in the exam that which questions are pilot and which questions are scored. So it will be totally blended, and you have to answer 150 questions to get your result. If you are unable to finish the exam, then your exam results will come as a fail. That's a very important thing. If you think that in the exam the time is running up, try to just answer something, all right, so that your exam results comes up. Otherwise they will just show it as a fail. So because it's a computer based, computer will not give you the result unless you finish 150 questions. Many of our candidates, like, when sometimes they did not know about that, and some of the candidates had those sort of bad luck before. So we don't want anyone to had this experience, so that now you know that 150 questions you have to answer completely, even if you don't know the correct answer, because there is no minus mark if you choose a wrong answer. So you can choose whatever you think that's best. Another important thing is the last 20 questions out of these 150 questions will always be scored. So try to make sure that you keep a little bit more time on the last 20 questions. It says that last 20 questions are very important to pass the exam, because they know that you will be in a hurry at the last times. They keep all the scored and more important questions at the last. So if you are not going with the time, sometimes you can miss that very important 20 questions. It's a 3.5 hours session, and it always is a computer adaptive software based exam. The good thing about First Aid AMC MCQ is that we have a very good software. It's just totally similar to AMC MCQ. if you guys heard from any of our current candidates, you will know that how tremendous our software is. You can appear exam like multiple times, and there are thousands and thousands of questions. So you will be like totally prepared for the exam, and don't bother with the software base because you will be prepared for that. And the past score is 250. Now this 250 score doesn't count it like if you um, like there is no particular mark for any of the questions. Some questions can be 2 marks, some questions can be 4 marks, 6 marks, and even 10 marks. So no one knows what is the mark of that questions. The difficult questions usually carries more mark, easier questions carries less mark. Sometimes that will happen that a candidate will say that all my questions were very easy and I think I did it all correct. Like most of them are correct, but still they would fail. Some other candidate will say that, oh, my exam was crap. All the exam questions were pretty hard, all the very big questions. I could not even finish reading that. Turns out that she passed the exam because the difficult, if you are able to answer correctly the difficult ones, the chances of passing increases a lot. That's according to the AMC. Okay, now for your MCQ exam, it's like this, like your 150 questions are divided into medicine, surgery, women's health, which is option gynae, pediatrics, psychiatry, population health, which is the biostatics. Now, it says that 30%, 20%, it's not like always they will follow the similar principle. Sometimes you will see that a candidate can get a lot of psychiatry questions and a very small amount of medicine questions. So there is no particular percentage or format, but it depends on your luck. Psychiatry questions are really hard in the exam. So it's not a very good luck, I would say, to get a lot of psychiatry questions because questions are really hard in psychiatry. Whereas medicine, gynae obstetrics, pediatrics, these are easy questions. And biostats, the population health, we have a very good set of questions, like which usually will be enough for your biostat preparation. So that was mainly just what I wanted to give you an idea. I know most of you might have this idea already, but still it's a good idea to refresh your knowledge. The last one is, this is your AMC scale. Your results usually will come up like a scale. See this 250, if you go, or if you're still like on the top of 250, you pass the exam. All right. So the AMC scale is a manifestation of your ability to answer questions appropriately. It's not like how many questions you have answered correctly. It depends on how many difficult and how many easier questions you have answered. Also, there is a term called mastery questions in the exam. Mastery questions are in between those scored stations. You will get some mastery questions. The questions which you will see that is very important, coming frequently in the exam always. I can assume some of the questions could be a mystery questions. Like if you see that there are pneumonia questions, very important for the exam. The exam questions related to back pain that are very important, related to prostate, very important. Then sometimes anuria after surgery, post-operative fever, post-operative complications. These are very important and coming very frequently in the exam. So obviously that could be the mastery questions, and mastery questions means they say that you have to pass at least 60% of that mastery questions. That also contributes to your AMC scale. I don't know like if you guys know all this thing or not already, but these are the important thing you should know before you appear in exam. Those who are in the live session in our Facebook group, are you guys able to hear me properly? You can write it in the comment section, then I will know. And I think those who are in Zoom, You can totally interact with me just by writing in the chat box. If you guys have any questions at any time, just ask me. Okay. All right. So let's move on to our psychiatry session. For your psychiatry, what are the important books you should always have on your side? You should always have your JM 7th edition. You should have your Kaplan Step 2 CK. You should have some idea on some of the important websites like Range CP, Medscape. These are important websites. You can take some help. World USMLE, that's obviously you guys should be doing this one before you appear the exam. Psychiatry is all about how is your basics. Even though if you do 100 or thousands of questions, you might not be able to answer correctly in the exam. It depends on how is your basics, and your basic will be a very, very sharp if you go through the World USMLE questions. They give the questions and they also answer the questions thoroughly, and it will be very helpful for you. And lastly, you should obviously go through our lecture notes, which is very comprehensive for your psychiatry preparation. And also we have a range of question solvation file. That questions are very important. You should always go through that before your exam. And lastly, you can obviously appear our software exam in our psychiatry software questions, and then you will able to see that how is your preparation on psychiatry. Now we'll start with more easier topics first, and then we'll move forward. Psychiatry, we take 3 classes for psychiatry in our course group. So today's class will be the class 1. So mainly today's class will be dependent on depression, bipolar disorder, schizophrenia, delusional disorder, and some other form of schizophrenia. These are the topics which comes frequently in the exam. And even though it seems very easy, I will show you that how many questions can come from these topics. Depression. Major depressive disorder is a term which show mainly that what is depression. If you are feeling upset, if your mood is low, if you cannot concentrate properly, that's depression. But it's not how the exam works. You have to know the criteria of MDD. Let's see the questions. 70-year-old woman recently admitted after her son informed the doctor that she had been doing very poorly over the last few months. The patient reports a 30-pound weight loss, decreased concentration, feelings of helplessness and hopelessness, decreased energy, depressed mood, and decreased sleep. Now, if you want to diagnose someone with a major depressive disorder, the criteria will be at least 5 of the following should be there for at least 2 weeks. Now you see that there are 9 criteria in here. Among the 9 criteria, 5 should be there. Then only you can diagnose major depressive disorder. Now among these 9, the first 2 is mandatory. So depressed mood and loss of interest. Loss of interest, another name is anhedonia. So anhedonia and depressed mood, among these first 2, at least 1 should be there. And from these 3 to 9, at least 4 should be there. Then it becomes total 5 symptoms. If anyone falls into these 5 symptoms, then you can diagnose it as a MDD. Remember, the duration of these symptoms should be at least 2 weeks to diagnose it as a MDD. It's very easy to remember if you remember the mnemonics, which is MCQ. What is MCQ? M for mood, which will be low mood. S for sleep changes, which is mainly insomnia. I for loss of interest. G for feeling guilty, hopelessness, worthlessness, mainly guilty feeling. E for lack of energy. C for lack of concentration. A for loss of appetite. P for psychomotor changes. Psychomotor changes could be psychomotor agitation, psychomotor retardation. What are those? Psychomotor retardation means patient will be slowed down on everything. And agitation, psychomotor agitation means patient will be like very much paced, irritable, okay, and hyper excited like that. And lastly, suicidal ideation. Among all these 9 criteria, which one is the most important thing that you should always look out in a depression patient? Guys, what do you think? What is the most important thing you should look for out of these 9 criteria in a depression patient? So the most, yes, Dr. Sultana, very good. So suicidal ideation, that's the most important thing you should look for. Okay, because any patient having a suicidal ideation, that means there is a severe depression and that patient needs hospital ideation, hospital admission. Okay, so very important to remember that. The mood, like the questions, you have to understand the question, all right? Like if they say what is the most important criteria to diagnose depression, that will be your mood changes. But if they ask what is the most important criteria you should look for in a patient with depression, that means you are looking for suicidal ideation. Clear? Apart from major depressive disorder, there are also some other subtypes of depression. One of the important for your exam is called persistent depressive disorder, which is PDD. Persistent depressive disorder is a mild severe depression for a long standing times, which is like more than equal 2 years. So if a patient has mild depression for a long time, which is more than 2 years time, then the condition is called persistent depressive disorder. Remember that, please. Now, sometimes question asks that what is the worst prognostic factor in a patient with depression? The worst prognostic factor is if a patient with depression has psychotic feature. Another question can come that what are the atypical changes or what are the atypical features in a patient of depression? Very important. Sometimes patient with depression can have increased appetite leading to increased weight. Patient can have increased sleep as well. Okay, so increased sleep, increased appetite, and increased weight. These can be sometimes the features of depression. So remember that because sometimes they can give it to you. Now come to the treatment. The treatment of depression depends on the severity of depression. So mild, moderate, or severe. Mild and moderate means that patient will not be that much severe enough to cause hospital admission. Like a patient can have low mood, lack of energy, lack of concentration, feeling of guiltiness. Those things can be there. Those will be mild to moderate. The question will indicate that how much severe the depression is. It will be very much evident on the look of the question. If it is mild to moderate depression, usually we will start with the psychotherapy, which is mainly cognitive behavioral therapy. Cognitive behavioral therapy usually given by a psychologist, not by a psychiatrist. Psychologist gives the therapy. So psychologist will try to convert all these negative feelings in a patient's mind into a positive feelings. That's mainly the basic of CBT. Sometimes CBT might not help in this patient's group, then you have to start pharmacotherapy, which is medication. Mainly we give SSRI for these patients. If patient is severe, like patient having suicidal ideation, patient having psychotic features, those patients need medication at the first. So you have to start SSRI for these patients immediately. And together with the medication, you can continue CBT as well. And the last option of severe depression is electroconvulsive therapy or ECT. ECT is mainly indicated for patients with severe depression with like there is no medication is working on this patient, no psychotherapy is working on this patient having severe depression with psychotic features, mainly geriatric patient, mainly older patients. And very important, if that patient stop or refusing drinks and eating. So if you get a patient like a 70-year-old patient, severe depression, having some hallucination, and she is refusing to eat and drink because she feels that if she, like we are trying to poison her by giving those meals or drinks, that patient is a candidate for immediate ECT. Okay, we'll go through these situations again. I'm just giving you some idea first. Now, the depression in children and adolescents also a very commonly asked question. The main difference between depression in adult and adolescents is that in children or adolescents, depression is not characterized by characterized by low mood. Rather, it's more towards irritable or very agitated, restlessness. Those are more common features rather than feeling low or upset. Okay, so irritability is the most prominent features for depression in an adolescent patient. Other than this, the criteria of adult and adolescents MDD is similar. So the same criteria should follow. Now the question is, if you want to give a medication to an adolescent for depression, what is the best medication for that? Anyone? What's the best medication you can give to a patient with depression? Like I know SSRI, but what SSRI? So do you think you want to do fluoxetine, fluvoxamine, paroxetine, or which one you want to give? Yes, Dr. Madhu and Dr. Asha, very good. So yes, you can give fluoxetine or fluvoxamine to this patient. Very important question, and it's also in your handbook. All right. So I just wanted to let you know that obviously before you go through the more psychiatry topics and things, please finish your handbook, MCQ handbook, because that will give you some idea as well. Okay, next one. Recurrent brief depression. This is from your GEM. Recurrent brief depression is a term which is characterized by if a patient has recurrent episodes of depression, but that doesn't fulfill the criteria of MDD. That means not lasting for more than 2 weeks. Rather, it's lasting for like 3 to 7 days, and then it becoming again normal, and then again it's coming as an episodic attack. That's called recurrent brief depression. Okay, so recurrent depression is when a patient has recurrent episodes of depression for short duration. Important thing about that antidepressants like SSRI are not effective for this particular condition. Mainly, management is depend on psychotherapy, which is CBT. Other than CBT, if you want to give some medication, then lithium will be the medication. That's very important to remember. Seasonal affective disorder, not very important. This is called winter blues. Sometimes patient can have recurrent depressive disorder in winter season, not very important. So that is your management guideline. Mild, moderate depression, we usually start with psychological therapy, which is CBT. Severe depression, mainly antidepressant. Now, I'm going to ask you these questions. Please read these questions very carefully and try to say that what is your correct option in here. A 72-year-old man comes to the office due to worsening depression and insomnia since his wife died 7 months ago. Patient experienced lethargy, tearfulness, little interest in socializing, attended 3 sessions of psychotherapy, but patient still feels depressed and having severe insomnia, difficulty falling and staying asleep. He feels very guilty about her death. Patient experienced a moment of severe depression last week in which he briefly thought of suicide because there is nothing left for me in this world. But he did not act on those thoughts. Also, there is a weight loss. What is the most appropriate next step in the management of this patient? If you look at this question, see that like it's a long questions, and psychiatric questions are difficult because of these long questions. They usually try to give you a very long questions, and then it takes some time to grab all the information. So you got a 72-year-old gentleman. Now, first tell me, is it a depression or grief? Because her wife died 7 months ago. Can it be a grief? No, it's not a normal grief because normal grief should pass after 6 months. So after 6 months, if still features of depression are there after the death of someone a patient loves, that is not a normal grief, that should be depression. And if you see that this patient has the criteria of MDD, so patient has insomnia, feeling low or tearfulness, lack of energy, then uh, feeling low, loss of weight, suicidal ideation, feeling guilty. So all the features of depression is there. For this patient who already had some psychotherapy, what you can do for this patient? So you want to increase the frequency of psychotherapy, prescribe amitriptyline. Amitriptyline is a TCA, tricyclic antidepressant, and continue psychotherapy. Prescribe mirtazapine. Mirtazapine is a kind of SSRI kind of drug, mainly SNRI. Continue psychotherapy. Prescribe zolpidem for insomnia. Continue psychotherapy. Provide reassurance. Recommend electroconvulsive therapy. What do you want to give to this patient? Remember, for like only choose electroconvulsive therapy in very severe depression in which there is psychosis, in which a patient, mainly when a patient stop eating and drinking, that's the best option to choose when you can choose the ECT. But other than this, don't choose ECT because you have some other things to try here. You haven't tried any medication yet, right? So try a medication first. So which medication you think will help? So obviously cross out the psychotherapy thing and also cross out the ECT. So now you have amitriptyline. So we don't usually use amitriptyline as a first line antidepressant because that's a TCA. We usually use SSRI or SNRI. So cross that out. Now you have two, mirtazapine or zolpidem. Remember, zolpidem can help with the insomnia, but we don't use it as a first line treatment because these patients having problem with deep insomnia. And mirtazapine, one of the side effects of mirtazapine is that it causes severe sedation. So if it causes severe sedation for an insomnia patient, this is the best medication. All right. So prescribe mirtazapine and continue psychotherapy. That should be your best choice of option in here. What if there is SSRI in this case? You should start the SSRI for any patient. Initially, SSRI should be the first. Like if this case, there was an option of fluoxetine or paroxetine, we would start the patient with the SSRI first. That did not help and patient still had severe insomnia, you could change to mirtazapine at that time. Now, when the changing came up for a depression patient, when you change antidepressant medication, you cannot stop suddenly and then you cannot start a new medication again. There will be a washout period in which patient should not take any antidepressant. Like if you if you if your patient takes fluoxetine for a long time, like for a long period of time your patient was on fluoxetine, which is a SSRI, even if you stop it today, in his blood fluoxetine will be there up to 7 days. Now if you stop fluoxetine today and you switch it to another medication like amitriptyline or in another SSRI like paroxetine, what will happen? So that patient's in that patient's blood still there is one SSRI, which is the fluoxetine. Now again you added another SSRI, which is paroxetine. What is the complication that can happen to that patient? So when patients take more than one SSRI medications, the very important complications that can happen is called serotonin syndrome, because this SSRI contains serotonin, and if you takes or if your patient takes more than one SSRI containing medications, that patient has a high risk of developing serotonin syndrome, which is a complication we don't want our patient has. Okay, so that's why patient should have a washout period. So if you think that you want to change an antidepressant from one to another, what you have to do, you will gradually decrease the dose of the first antidepressant that the patient was taking, and then you will stop it, give it a rest for a couple of days. Like sometimes most of the antidepressant you can keep a washout period like 2 to 3 days, but for fluoxetine it should be 7 days. And after 7 days, then you start the other medication. Okay, so that's how you should switch the antidepressant medication. That is called washout period. Any patient you want to switch one antidepressant to another antidepressant, there should be a washout period between these two antidepressants. Why? Because to reduce the risk of serotonin syndrome. Clear? Now, sometimes you will feel very much difficulty in the pharmacology related to psychiatry. So that's why we kept some of the important side effects of this medication. Most of the SSRI will cause insomnia. Some of them can cause sedation. Appetite change can be there. Sexual dysfunction is one of the very important complication of SSRI, and it happens for every SSRI. Sometimes patient can have abdominal pain, nausea, vomiting related to SSRI as well. Now, two questions for you guys, which is very important for the exam. One, if a patient is on fluoxetine or if a patient is on sertraline, which is a SSRI, and that patient is complaining abdominal pain, what you will do next? Let me answer the questions. So if a patient is on sertraline or any of the SSRI and they are complaining of abdominal pain, nausea, vomiting, you should change the antidepressant to another SSRI. So if a patient is on sertraline, change it to fluoxetine or paroxetine. Okay, so for abdominal pain, we change to another medication of the same group. But if that patient has sexual dysfunction related to any SSRI, then what you will do? Because all the SSRI causes similar percentage of sexual dysfunction, changing to another SSRI doesn't help. So the option for that person will be first watchful expectancy, like will not do anything, we'll just see that if the effects of medication wears off, but that's mainly helps in 10% population, so that's not a good option to choose. Second option is reduce the dose of SSRI. That's mainly we do. Sometimes patient can be on 100 milligram sertraline, and patient's mood is okay and depression is well controlled, but is still having a sexual dysfunction. What you can do, you can reduce that sertraline to 50 milligram. That's usually the first approach that we would do. Okay. Now, even if sometimes you may not be able to reduce the dose because patient's depression is not well controlled, or you reduce the dose but it still is not helpful, then what you can do, you can change to another antidepressants, but not the SSRI group, but SNRI group. So you can change it to metazapine. That's a good option to choose. Another thing that you can do, you can add sildenafil, which helps with sexual dysfunction. That will be our last option to choose. So any patient having sexual dysfunction related to antidepressant, mainly SSRI, our first option will be reduce the dose if possible. Otherwise, change to another antidepressant, but not the same SSRI. We will change to another, like we can try SNRI, like metazapine we can try, or other SNRI also we can try. The last option will be to add a sildenafil for erectile dysfunction or sexual dysfunction. Very, very important for your exam. I also kept few of the SSRI side effect. You guys can have a look later on. We already discussed. Metazapine side effects. Remember, metazapine causes severe sedation and it causes weight gain. It can increase serum cholesterol level. It can cause drowsiness because of severe sedation. It can cause constipation. Insomnia is not a very important feature for metazapine. So most important side effect is severe sedation. Now there is also sometimes we prescribe venlafaxine for patients with depression. Now venlafaxine also, it can cause, main complication that you should look for is insomnia. Venlafaxine is like very notorious to cause insomnia. That's not my problem. My problem is sometimes they will ask that a patient is on venlafaxine for a prolonged period of time. What is the important thing you should look for in that patient? The answer should be blood pressure, because venlafaxine is very, very notorious to cause hypertension. And sometimes it can also increase the suicidal risk in young children. That's why venlafaxine is not an ideal drug to use in children or adolescents or young adult with depression. Clear, everyone? So we have been discussing about serotonin syndrome earlier. So serotonin syndrome occurs when there is increased dose of a serotonergic agent, or if you give one or more SSRI medication in the same patient. It's not only the SSRI that increase serotonin in a body. Sometimes some other medication like opioids, tramadol is very notorious. Some stimulant drug like ecstasy, MDMA, those illicit drugs can also cause serotonin syndrome. Antiemetics like domperidone, lithium also very important, and sometimes MAO inhibitor like selegiline can cause it. What are the symptoms that you will look for in a serotonin syndrome patient? Three things. First of all, mental status. So patient will be confused and agitated, can have seizure as well. Muscle tone. Patient can have tremor, shivering, hyperreflexia, and autonomic instability. If you look at here, this is a very good picture of how serotonin syndrome patient looks like. They will be agitated and very much sweaty because of autonomic hyperactivity. They can have tachycardia and hypertension. Very important is mydriasis, which is dilated pupil. That's very important diagnostic factor. And you should always look for hyperreflexia and clonus. That's also important. And those patients can have tremor as well. Because of autonomic hyperactivity, the patients can have increased bowel sound or increased peristalsis causing diarrhea. That's mainly your serotonin syndrome. What will be the management of serotonin syndrome? First thing to do is to stop the offending drug. If it is like patient is on 2 or 3 SSRI containing medication, you should stop all the medication. And then you should stop it abruptly. At that time, there is no time to gradually reduce the dose. So any patient having a serotonin syndrome and is on some of the serotonin containing drugs, stop the drugs immediately and then the supportive management. There is a questions like, anyone knows that there is an antidote for serotonin syndrome? What is the name? Very good, Dr. Maria. So, yep, cyproheptadine. So the last choice will be like if a patient becomes very seriously ill, that time we will try cyproheptadine. Good, very good. Okay, let's move on. Now, this is a chart that can help you solving many exam questions. Difference between serotonin syndrome and neuroleptic malignant syndrome. Serotonin syndrome, you know what it is, but what is neuroleptic malignant syndrome? This is a condition in which a patient is on an antipsychotic medication and develops some of the neurological manifestation, which is mainly muscle rigidity, hyperthermia, like increased body temperature, decreased or absent reflexes. That is mainly a neuroleptic malignant syndrome. Neuroleptic malignant syndrome is the complication of antipsychotic, serotonin syndrome complication of antidepressant. These are abrupt onset. This is gradual onset. Main feature of serotonin syndrome is it causes tremor and myoclonus, but this causes diffuse rigidity of the muscle. Reflex will be increased here, decreased or absent here. Pupil will be dilated in here, pupil will be normal in neuroleptic malignant syndrome. Okay, so this is how we differentiate between these two, because what can happen in the exam, they can give that patient is on both antidepressant and antipsychotic. Now what you will do, you have to rely on these differentiating factors. Okay, next, a patient is on antidepressant, how long he will continue that? So if it's the initial episode of depression, then minimum 12 months we have to continue the antidepressant. But if a patient has like more than one episode of depression, for that case, we have to continue at least 2 to 3 years. All right. And also just give it a read that who are the patient having a risk of relapse. So that was all about the depression, guys. I know it took a little bit of time, but it worth. I don't think that after discussing about this depression, there will be any question left to solve. Okay, so That was about depression. Do you guys have any question on depression that I can help with? All good? Okay. Next one is your bipolar disorder. Another important topic. If you look at this picture, this defines what is bipolar disorder. A patient has two pole, like one is a good, like norm. Let's say that this is the median in which patient has a normal mood, and this part when a patient is depressed, and this part when a patient is like, sorry, so this part which is patient is depressive, this part when a patient mood is normal, and this part when the patient's mood is elevated. The bipolar disorder means when a patient shows the feature of low mood sometimes and elevated mood sometimes, that's your bipolar disorder. The elevated mood is called mania, and low mood you already know, that's depression. So when depression and mania is is a feature in one particular patient, when both mania and depression occurs in the same patient, that's your bipolar disorder patient. The main component of bipolar disorder is mania. So what are the criteria mania should follow? If you want to diagnose a patient with mania, patient should have at least 1 week of abnormal behavior. First behavior is abnormally elevated mood. So elevated, expansive, irritable mood, and then three or more of the other features. So one of them is inflated self-esteem, which means patient will have grandiosity. So when a patient feel like I'm having some superpower, okay, I'm superior to others, that is a grandiosity or increased self-esteem. These patients will have decreased need for sleep. So patient will say that, doctor, I don't feel any need for sleep. I'm totally fine. I haven't slept for the last 7 days, but I don't feel tired. So increased energy, no need of sleep, and it will be very talkative patient, talkative and loud. Then racing thoughts or flight of ideas. What is flight of ideas? Which means that when a patient's topic of discussion changes very frequently. Like I'm talking like, well, moon is on the bus is on the cheese is on the table. So kind of like my ideas are just changing. But there is still a little connection between each sentence I'm talking, right? I'm talking moon is on the bus is on the cheese is on the table. So a little connection is there still. That's flight of ideas. But there is another term which schizophrenia patient shows, that loosening of association. In that case, there will be no connection, total loss of connection on whatever patient is talking about. So flight of ideas is important for mania. Patient will be very distracted. Increased goal directed activity, which means patient was previously patient could not finish one semester in the university, but now when the mania came up, patient has enrolled himself in mathematics, in engineering, in science, in most of the research projects. So increase goal directed activity, but patient will be unable to focus on a particular thing because they are distractible. And in excessive activity, which means that they will have mainly reckless behavior. So increased sexual drive, increased spending, okay, increased drug abuse. So those are also very important feature of mania. If you want to diagnose a patient with mania, that the criteria should be followed, and that should be at least more than a week. Last thing is that should cause a severe impairment of social, occupational, and familial life. Okay, these three things, if it is there, then only we can say it's mania. What if the symptoms are not very severe, it's not causing any social or occupational problem, and the duration is less than a week? What's the condition called? Hypomania. So mania and hypomania, these are important for your bipolar disorder. You can easily remember by memorizing DIC first. DIC first is the criteria for mania. D for distractibility, I for insomnia, G for grandiosity, F for flight of ideas, A for activity like increased goal-directed activities, S for speech. This patient has pressured speech, which is like loud talkative speech, and thoughtlessness. Thoughtlessness means that patient will have increased goal-directed activities and mainly risk-taking behaviors. So increased sexual drive, reckless driving, traveling to many areas, and spending a lot, gambling. So all these are features of mania. Mania patient needs to be hospitalized. Okay, the first management for any mania patient is hospital admission. Even if patient doesn't want to be admitted, involuntary admission needs to be done. There is two terms. One is called bipolar 1 disorder, another is called bipolar 2 disorder. What are those? Let's see first this question. 19-year-old college student is taken to the school counselor after he fails several classes. The patient is enrolled in numerous classes, most of which have conflicting times. Grades are poor, yet he seems undisturbed by this. He also enrolled in numerous organizations like chess club, drama club, student government, sports, and list two fraternities. Speech is pressured and having psychomotor agitation. What do you think this patient is having? So obviously this is a mania, because if you see that the thing is like they haven't given us that how long this is happening, but let's assume that this was more than a week, and obviously you see that he's failing several classes, so it's impacting his life. That's mania. And also you see these patients enrolled, so multiple goal directed activity, pressured speech, psychomotor agitation. So it's a kind of mania features. Now, how we can say which one is bipolar 1, which one is bipolar 2? Bipolar 1 disorder has one fully fledged manic episode plus usually depression episodes. So to diagnose bipolar 1, patient should have at least one manic episode. If a patient doesn't have any manic episode but has hypomanic episodes and depression, then it will be bipolar 2 disorder. Management is pretty much same for those two, but the name is different. So bipolar 1 when depression with one manic episode, that is bipolar 1. Bipolar 2 when depression associated with only hypomania but no manic history. Management, very important. This is a medical emergency and it requires hospitalization, and even if involuntary, as I said. A recent meta-analysis indicates that antipsychotics are the most efficacious drug. So most effective drug for acute mania is antipsychotic. Please remember that, because many candidates I have seen, they are choosing lithium as a acute mania treatment. No, in any patient having acute mania, your initial treatment should be antipsychotic, and you should start with either olanzapine or risperidone. If that is not in the option, then you have option of choosing haloperidol or other antipsychotic like aripiprazole, lithium, or some other mood stabilizers like sodium valproate or carbamazepine. But first line is antipsychotic. Lithium is not a first line medication for acute mania treatment. When we choose lithium, when a patient has one episode of mania, they are increased risk of having more mania. So we give preventive medications for those patients, kind of prophylaxis. And lithium is the best preventive medication for bipolar disorder. Remember, so first line is olanzapine risperidone. If that's not in the option, haloperidol or other second generation antipsychotic, lithium, sodium valproate, or carbamazepine. Prophylaxis for recurrent bipolar disorder, that's your lithium. Or sometimes you can, if lithium is not in the option or if lithium is contraindicated, then you can use second generation antipsychotic, which is olanzapine, risperidone, aripiprazole, all those. Or you can use mood stabilizer like carbamazepine or sodium valproate. But first line preventive or prophylactic medication for bipolar is lithium. When a patient is on lithium for long term, their risk of lithium toxicity increases. That's why there is a rule to do frequent lithium level in those patients. How you will understand lithium toxicity in a patient? Usually, lithium toxicity is manifested. Normally, they comes with nausea, vomiting, tremor, hyperreflexia, agitation, weakness, and ataxia. Sometimes they can be having hypertonia or hypotension, and in severe case, cardiovascular collapse, or patient even can get into coma or seizure. Main feature of lithium toxicity is nausea, vomiting, tremor, muscle weakness. Lithium can cause kidney failure, and very important complication of lithium is called nephrogenic diabetes insipidus. It causes nephrotoxicity and it causes nephrogenic diabetes insipidus, and it also causes hypothyroidism. These are common complication and important complication you should remember. Now, if you find out a patient is having this lithium toxicity feature, what is the next thing you should do? You should check the lithium level first. After checking the lithium level, if lithium level is less than 4 and patient doesn't have any severe feature, you can just treat it as a conservative management. That means stop the lithium and give some normal saline, because most of the time it's the dehydration causes more trouble in lithium toxicity. So hydrate the patient. But if the lithium level is more than 4, even the patient is not symptomatic, that patient is a serious lithium toxicity patient. What is the management for that patient, guys? So lithium toxicity causing severe features like having cardiovascular collapse, having renal failure, or patient is comatose, patient has a seizure, that patients need dialysis. Or if lithium level is more than 4, again dialysis. Remember that, please. Now, when lithium is contraindicated, if these features are there, if a patient is hypothyroid patient already, you cannot use lithium. If a patient has renal failure, you cannot use lithium. If a patient has extensive cardiac history, you cannot use lithium. If a patient has history of epilepsy, you should be careful using lithium. Now, very good question, Dr. Jahara. Can you use lithium in pregnancy with caution, whose symptoms are well controlled with lithium? Now, if a patient, normally for bipolar disorder in pregnancy, there sometimes can be a need to use lithium. Now, if a patient is on lithium and the symptoms are well controlled for more than 2 years, then you should stop lithium. Okay, you should stop lithium before the pregnancy, and you can try a lithium free pregnancy because symptoms are well controlled. Okay, that's the first option that you would do. Now, what if you cannot stop lithium in pregnancy because patient is not well controlled? At that time, the option is two options. One option is you should not use lithium in the first trimester. So first trimester stop lithium, and then from the second trimester continue lithium. That's a safer option. And if patient is a very severe bipolar disorder patient, then you should continue the lithium throughout the pregnancy, keeping in mind that lithium can cause some complications in pregnancy. Clear? So if it is well controlled before pregnancy, try to stop lithium. So gradually reduce the dose of the lithium and then stop it before pregnancy. But if you need to continue lithium, then stop it in the first trimester, then restart from the second trimester. Now, the next topic is management of bipolar depression. Sometimes there will be situations in which the patient just came up with a depression and you have given antidepressant, because normally that we should do, and that patient turns out to be a mania patient just after a few weeks. What you have done is that most likely that patient had underlying bipolar disorder, and you just aggravated that manic episode by giving only antidepressant. The thing is that if a patient has underlying bipolar disorder, and if that patient is only given antidepressant, there is an increased risk of mania. But some of the things that we cannot avoid this thing, but we have to be very careful. We have to ask that if this patient had any time, any high mood, any family history of mania. So we have to be careful, mainly in a young adult patient. But if it's already diagnosed bipolar depression patient, that means patient had previous episodes of mania and also depression. Now patient is having mainly depression. Your treatment should include both antidepressant and mood stabilizers, which means antidepressant SSRI with either lithium, valproate, carbamazepine, or antipsychotics. Mainly you can continue lithium because you are giving the maintenance treatment. And when the depression phase over, you will gradually reduce antidepressant and stop antidepressant, and the patient will continue taking lithium just as a maintenance treatment. See the last line, antidepressants are usually withdrawn within 1 to 2 months because of increased risk of precipitating mania. Okay, let's see one thing. This is your question. Now you will answer this question because we just discussed it now. So a 27-year-old man is brought to the office by his wife due to her concern that he has not been himself for the past 3 weeks. She says that he is depressed and withdrawn, sleeps 14 hours a day, no energy or interest. Patient hospitalized 6 months ago for an episode in which he became aggressive toward his wife. This occurred when she confronted him about staying up all night, gambling away their savings, investing a large sum of money, and also patient spoke very rapidly at that time and convinced that he had a brilliant plan to achieve world peace. So what was that episode at that time, 6 months ago? Mania, right. So that patient had a mania episode 6 months ago, and now the patient is having depression. So this patient is a bipolar disorder patient, and it's a bipolar disorder 1 or 2. Most likely it's bipolar 1, because I think from the question it should be a mania patient. And patient also had these similar episodes 2 years ago. Which of the following medication are most appropriate for the maintenance treatment for this patient? So for the maintenance treatment for this particular patient, what you will give? Carbamazepine and fluoxetine, lithium and quetiapine, lithium and sertraline, and lorazepam, risperidone, valproate, clozapine, valproate, haloperidol. So think clearly, this patient is a bipolar disorder patient, had a mania previously, now patient is depressed. So you have to follow this criteria. So an antidepressant and a mood stabilizer. So what do you think should be the option? So you have got lithium, which is a mood stabilizer, and you have got an antidepressant, sertraline, right? So these two will be the best option, because no, you have to choose the best always. Now, lithium and quetiapine is also an option, but both of these, lithium and quetiapine, both are mood stabilizer. But what about the depression patient is having now? You're not giving anything. You have to give something, right? So this two is not important. Carbamazepine, fluoxetine, well, this could be an option if lithium and sertraline was not in the option. Okay, and others are same. So best option to choose in here, it will be C, because lithium is the best maintenance treatment for mania, and for depression now, the best antidepressant will be sertraline. Just couple of questions on other disorder. One is persistent depressive disorder. The other name for this condition is dysthymia. You already discussed that if a patient has depressed mood for more than equal 2 years, we call this as a dysthymia. Nothing much you need to know from here. Another is called cyclothymic disorder. Read the question. Mrs. McDonald has experienced a 12-year history of periods of feeling great followed by periods of feeling lousy. So 12-year having like elevated mood and depressed mood. During her feeling great period, she experienced increased sexual drive, euphoria, increased irritability. And during her feeling lousy, she experienced insomnia, fatigue, and low self-esteem. So you should understand what is cyclothymic disorder. It's a condition, it's a chronic disorder in which a patient has many episodes of depression and many episodes of mania for at least 2 years. So when only depression for 2 years, that's dysthymia. When bipolar disorder for 2 years, that's cyclothymic disorder. For cyclothymic disorder, you have to give some mood stabilizers, mainly lithium. The last thing from depression part is grief and depression. The term grief and depression is very interrelated, and it causes some confusion during the exam. Like the grief means within the 6 months of losing someone who you love, if a patient has features like feeling upset, tearful, sadness, decreased sleep, so features of depression are there, but within 6 months of losing someone, that's called grief or bereavement. But when it becomes more than 6 months, and if the features of MDD is there, then it will be a depression. Another condition called complicated grief. Complicated grief means When a patient with normal grief also has features like patient is having hallucinations, some abnormal belief also, that's complicated bereavement. Also, I would say complicated bereavement, like if a patient has more than 6 month grief-like features, but it doesn't fulfill the criteria of MDD, that's also complicated grief. How to differentiate between grief and depression? Mainly, this is the cutoff 6 months. Also, grief patient symptoms is not persistent, but depression is persistent symptom. Suicidal ideation is not common in grief, but depression is very common. And for treatment of grief, we don't use SSRI for treatment of grief, just supportive psychotherapy, which is CBT. But for depression, sometimes we might need to give medication. All right, we discussed some questions like this, so no need to discuss this one. Okay, so that was mainly your depression, bipolar disorder, grief. Okay, the next one we are going to do is schizophrenia. Before we go into the schizophrenia, we'll take a 10-minute break because psychiatry, you need a calm and quiet mind, and the human brain doesn't act like more than like already we have taken 15 minutes class. I don't think anyone is listening. So we'll take a 10-minute break, take some drink, eat, you can drink some tea, coffee, whatever you like, and then come back again, please. Okay, then we'll finish important topics related to schizophrenia and delusional disorder. Thank you. During this time, if you have any questions, feel free to ask me, or you can write it in the comments. Those who are in the Facebook, those who are in the Zoom, write it in the chat box. Thank you all. So we'll come back in 10 minutes time. All right, doctor. So let's start again. So now we're going to discuss about the schizophrenia, very important topics for your psychiatry. Schizophrenia means that what we understand about psychosis is schizophrenia. When a patient loses the touch with the reality, then it's called schizophrenia. Symptoms of schizophrenia must be there for at least 6 months to make a diagnosis of it. And it's very commonly, it's usually occurs in between 15 to 25 years of age. Increased risk if there is a family history of schizophrenia. This risk is important for your exam. You have to memorize the risk. So general population is 1% risk of having schizo. If there is one schizophrenic parent, then 12%, two schizophrenic patient, 40%, one first degree relative, then 12%, one second degree relative, 5 to 6%. Monozygotic twin has highest risk, which is 47%, and dizygotic 12%. You have to memorize that. Now, what are the features of schizophrenia? Right? So, the main features of schizophrenia is hallucination, mainly auditory, delusion, which is bizarre kind of delusion, disorganized speech or behavior. The features of schizophrenia, you have to have at least one of these three to diagnose schizophrenia. So you have to have delusion, which means abnormal false belief, hallucination. Hallucination means impaired perception. Like if a patient can hear, uh, like patient hearing that someone is talking about him, but there is no one in the room. That's auditory hallucination. If a patient can see someone in the room, but you cannot see or no one can see, that's visual hallucination. If a patient can feel something is crawling up in their body, but there is actually nothing, that's tactile hallucination. Can you tell me, there is a drug which causes tactile hallucination? It's an illicit drug. What's the name of that drug? Cocaine. Very good. So cocaine abuse can cause tactile hallucination. Important for your exam. Then disorganized speech. As I said, the people with schizo has loosening of association. So whatever they are talking, you will not understand most of the time. Then grossly disorganized behavior and some of the negative symptoms. Negative symptoms like flat affect, social withdrawal, those are negative symptoms. Obviously, this feature should be there at least 6 months. Okay. So if a patient doesn't have one, at least one of these three, you cannot diagnose it as a schizophrenia. And also with one of these, like what if a patient has only delusion but no other feature? Everything is good. That's not schizophrenia, that's only delusional disorder. So patient should have at least one out of these three, and also some of the disorganized behavior or some of the negative features. So these are called positive and negative symptoms of schizo. Positive symptoms are delusion, hallucination, thought disorder, and disorganized speech and behavior. Positive, why it says positive? Positive behavior means which a normal person doesn't have, schizophrenia patient has that. That means it's a positive point for them. Negative means a normal person has something, but schizo patient doesn't have that. Like flat affect, thought poverty, lack of motivation, social withdrawal, reduced speech output. So these are the features of schizophrenia we have to think about. Always try to rule out illicit drug abuse because that can also present with similar psychotic features, which we call drug-induced psychosis. Most importantly, marijuana, amphetamine, this causes psychosis. Now the medication. If you want to start medication in a schizophrenia patient, we have antipsychotic medication, first generation and second generation. First generation are no longer used as a first line treatment. First generation causes a lot of side effects. Your first generation are chlorpromazine, haloperidol, trifluperagine. All these causes increased risk of extrapyramidal side effects, EPS. So nowadays, it's the preferred medication is the second generation antipsychotic, which is your olanzapine, risperidone, okay, aripiprazole, those medication. So if you want to start antipsychotic, you have to start with olanzapine or risperidone as a first line treatment. Usually response of this medication starts within 3 to 4 weeks. If within 4 to 6 weeks of starting a particular medication, patient doesn't have any response, then you have to change it to another second generation agent. And last option will be your first generation. Don't start first generation immediately. Also, this patient needs a chronic period of antipsychotic medication. So usually we use olanzapine or risperidone or quetiapine. Chlorpromazine causes photosensitivity reaction. All right. Also, it's notorious to cause impairment of retina. Sometimes it can cause retinitis pigmentosa. Okay. So normally we should start with the oral medication. Sometimes we may need to use long-term like depot preparation, but we try not to use depot because depot preparation has long, like these are long acting. It needs like about 1 month to kick in. So usually you start with the oral therapy always. If it is a drug resistant schizophrenia, when we call drug resistant, if you try 3 antipsychotic, mainly second generation antipsychotic, still patient's schizophrenia is not controlled, that drug resistant. What is the option? Start the last resort, which is clozapine. Clozapine is the best medication for any schizophrenia, but why we cannot use it? Because it has a very, very severe side effect profile. Because it causes cardiotoxicity, it can also cause blood dyscrasia, mainly agranulocytosis or even pancytopenia. So any patient you want to start clozapine, you should first try 3 antipsychotic medication. If that doesn't work, the fourth option will be clozapine. When a patient is on clozapine, you have to repetitively measure clozapine level. And if that patient comes to you with chest pain, you have to immediately think about a particular complication of clozapine called myocarditis. You have to do an ECG and a troponin immediately. And also, you should do complete blood count to rule out any blood problem it can cause. So mainly, how you are monitoring a patient on clozapine, doing a full blood count, ECG, troponin. If patient fails to clozapine, then the last option, sometimes we have to try ECT as well. Okay, so this is a ladder of approach. You have to remember that, otherwise it will cause a lot of confusion. Now, what are the side effects of these antipsychotic medications? Because that's the main part from where a lot of question comes. You have to remember these are the extrapyramidal side effect. It doesn't mean that only first generation antipsychotic causes EPS, second generation also can cause it. but it causes less EPS than first generation. For acute dystonia, so acute dystonia is one of the EPS. What is characterized by patient will have like kind of on and off muscle spasm, mainly the facial region. So face, neck, tongue, all right. And sometimes they can have some oculogyric crisis, kind of like disproportionate movement of the eyeball or dancing of the eyeball. So this is dystonia, mainly a spasm of the face, neck, tongue, that is dystonia. The treatment is add benzotropine for those patients who is having EPS. You don't need to stop the medication. You can add benzotropine. Then akathisia, very important complication. Patient usually comes to you with subjective restlessness. So patient cannot sit anywhere, very restless, and always moving the feet and legs. So that's akathisia. First, you should try reducing the dose. If reducing the dose doesn't help, then again try to use propranolol, diazepam, or benztropine. Okay, so either propranolol, diazepam, or benztropine should be your second line treatment for akathisia. First, try to reduce the dose. See if the symptoms resolve or not. Then the third one is called Parkinsonian symptoms. Parkinsonian symptoms means the patient will develop Parkinson-like symptoms like slowness of the movement, then gait disorder, Parkinson gait. Patient will have like stooped posture. Okay, so this is, and also rigidity. They can have some resting tremor. That is Parkinsonian kind of symptoms. That is a complication of antipsychotic drug. First line will be try to lower the dose or substitute a phenothiazine kind of drug in low dose. Mainly, if low dose doesn't help, we can try benztropine or benzhexol. Benztropine, benzhexol is very good to reduce the anticholinergic side effects of these medications. So mainly if patient is complaining of tremor, then benztropine or benzhexol is a very good medication for that. Tardive dyskinesia. What is tardive dyskinesia? It's mainly, remember, it's a long-term antipsychotic drug complication, so immediately it will not come. Tardive dyskinesia is involuntary movement of face, mouth, tongue, and trunk. So patient will have like kind of like abnormal movement of the face, mouth, tongue, trunk, and limbs. Tardive is a long-term complication, whereas dystonia is an acute complication. This is how you can differentiate. Treatment, usually try to stop the medication. If stopping the medication doesn't help, then you can use tetrabenazine. All right. Sometimes this tardive dyskinesia can be confused with other involuntary movements like chorea, athetosis, dyskinesia. Okay. Mainly involuntary movements of face, tongue, mouth after continuing the antipsychotic for a long period of time. That should be tardive dyskinesia. The last one, but the most important complication is neuroleptic malignant syndrome. Okay. Now, neuroleptic malignant syndrome, it's a potentially fatal adverse defect. That's because it can develop in hours to days of starting the antipsychotic. Mainly, patient will have very high temperature, muscle rigidity, altered consciousness. Then also you have seen that this patient will have uh, lack of reflex or decreased reflex. Okay, so that's mainly the feature of neuroleptic malignant syndrome. First treatment is to stop the medication immediately. Symptomatic management like IV fluid, hydration. If it is becoming very severe, then you can give bromocriptine and dantrolene. This will reverse the effects of antipsychotic. Clear? So we have got these are the 6 extrapyramidal side effect. So acute dystonia, treatment is benztropine. Akathisia, reduce the dose or use propranolol diazepam benztropine. Parkinsonian, reduce the dose, use benztropine benzoxazole. Tardive dyskinesia, stop medication or use tetrabenazine. Neuroleptic malignant syndrome, stop medication and then use bromocriptine dantrolene. Now this chart is like, it will be a life saving for you guys. Like sometimes very much, like I have seen a lot of questions coming from this antipsychotic side effects. You have to have a very good idea on this thing. Main thing you should look for is aripiprazole, clozapine, olanzapine, quetiapine, and risperidone. These are the main important antipsychotics that are commonly used. First, look at olanzapine and quetiapine. Olanzapine, it causes dyslipidemia. So mainly olanzapine and quetiapine, these are same. Both of them causes increased weight gain, all the metabolic syndrome kind of features. So dyslipidemia, hyperglycemia, then it causes a kind of sedation also, but weight gain is common. Okay, so weight gain, hyperglycemia, dyslipidemia, that is olanzapine. Same is quetiapine, also causes dyslipidemia, hyperglycemia, and weight gain. And also it's sedative kind of. Okay, so these are pretty same. Now look at the risperidone. The main complication of risperidone is hyperprolactinemia. Hyperprolactinemia, it causes galactorrhea. Okay, that means kind of whitish or milky discharge from the breast. Risperidone is very notorious to do that. Also, it can cause orthostatic or postural hypotension. Look at clozapine. Clozapine is like very notorious to cause this dyslipidemia, hyperglycemia, orthostatic hypotension, very much sedative, and weight gain. So same like olanzapine and quetiapine. Look at the aripiprazole. It's a very good one because it doesn't cause any dyslipidemia, hyperglycemia, or weight gain. So if this the aripiprazole can be used in a patient who is having the complications of olanzapine, like weight gain or dyslipidemia or diabetes, right? Also, you see it doesn't cause any hyperprolactinemia as well. So side effect profile for aripiprazole is very low. But why we don't use it at the first time? Because it's not very effective. That's why. Now, the question is, if a patient is on risperidone, let me write this question because these are the things you guys will not get it correct in many other areas. So I want you guys to know this thing. So if a patient is on risperidone and then patient develops galactorrhea, what the next thing that you can do for this patient? What is the problem with the audio? Is anyone having a problem with the audio? I don't understand. So any patient on risperidone with a galactorrhea, first thing you to do is to stop risperidone and try to switch the risperidone to another antipsychotic which causes less hyperprolactinemia. We can check the prolactin level, but the question usually asks for changing to another antipsychotic. What antipsychotic you will try? You will try aripiprazole. Sometimes aripiprazole not in the option. What you will do? The next option will be quetiapine. Now, the next question, patient is on olanzapine and patient developed diabetes or weight gain. What you are going to do? For this sort of patient, again, try to change to aripiprazole. Together with that, lifestyle modification should be a good idea. Okay. Now, very good question. Can we stop it suddenly? No. What we'll do, when we change an antipsychotic to another antipsychotic, we follow a particular rule called crossover period. Just like washout period in antidepressant, we have crossover period in antipsychotic. What is crossover period? So you want to change one antipsychotic to another one. What you are going to do, you're going to gradually reduce the dose of first antipsychotic patient was taking long time. So gradually taper though that one. Same time, you also add the second antipsychotic at a low dose. And then you gradually increase the dose of the new antipsychotic. So what will happen? Let's assume patient is on risperidone and now you want to change it to olanzapine. Okay, so what you will do, you will do the crossover time. So you will gradually reduce risperidone and add olanzapine at the same time at a low dose. So you will gradually reduce risperidone and gradually increase olanzapine. At one time, risperidone will be at a very low dose, then you can stop it and then you will just continue the olanzapine. During this crossover time, patient should be admitted in the hospital. Clear? All right. Now, some other important disorders which is associated with schizophrenia is brief psychotic disorder. Brief psychotic disorder in one line when the patient has psychotic feature but that last less than 1 month. So look at this question. 35-year-old female Chinese immigrant brought in by neighbors after she was found wandering in the streets, yelling out someone's name. She appears disabled and grossly disorganized. You learn that she arrived in the US several days ago. Upon her arrival, witnessed the death of 3-year-old son. While in the waiting room, she appears to be responding to internal stimuli. What is appearing to respond to the internal stimuli? That's hallucination. This is how they sometimes say hallucination. So when someone responds to internal stimuli, that means some abnormal perception is going on. That's hallucination. Then patient is grossly disabled and disorganized. So you have got two important criteria for psychosis. But this is for how long? She just came up, right? So several days ago, she came to the US and then witnessed the death of her 3-year-old son. Usually this brief psychotic disorder has some stressor and patient starts to have all these things. But usually it's never last more than a month. So less than 1 month, but more than 1 day. That's brief psychotic disorder. Any patient having active hallucination should be hospitalized. So this patient also needs to be hospitalized because to ensure her safety as well as other safety. And this patient also needs to be started with antipsychotic medication. Next, schizophreniform disorder. What is schizophreniform disorder? So patient has psychosis behavior. That means all the psychotic behavior, hallucination, delusion, all those criteria are there, but just the duration. When the duration is between 1 month to 6 months, so when it is between 1 to 6 months, but not more than 6 months, then it's schizophreniform disorder. So let's read this question. Mrs. Jones is evaluated at a nearby clinic after she was noticed to be acting inappropriately at work. According to her co-workers, she began acting strangely 3 months ago. So it's 3 months ago all this started. At the time, she began wearing a hard hat to work. When asked, she replied, "I will not let you read my mind." So what is this? Do you know what is this particular line called? This is called abnormal belief, which is delusion. She also believed that others were talking about her. If someone believes that others are talking about her, that's also a particular delusion. Do you know what is the name of that delusion? The delusion is called delusion of reference. Okay, so delusion of reference also she is having. On several occasions, she had to be escorted out of the room because she started to argue with others whom she believed were controlling her mind. All right. So you have got a schizophreniform disorder patient. So what you have got, patient acting inappropriately, which is disorganized behavior. Patient started all this strange behavior 3 months ago, and patient is having delusion. So it fulfills the criteria of psychosis, but it's less than 6 months. So it will be schizophreniform disorder. Again, this patient will need antipsychotic medication, usually 3 to 6 months period. So we have got three conditions according to the duration. Less than 1 month psychosis, that's brief psychotic disorder. 1 to 6 month psychosis, that is schizophreniform disorder. More than 6 months, it's schizophrenia. The next thing is a schizoaffective disorder. Schizoaffective disorder, as the name implies, you can see the schizo plus affective. Affective means it contains depression or mania, which means bipolar. All right. So when a patient has both psychotic features with bipolar disorder feature, that's a schizoaffective disorder. Let's see the question. 25-year-old woman is found walking nude in the shopping mall. When asked, she replies, "I am making it easy for others to have sex with me since I know they all want me." So this is delusion. She states she heard a voice telling her she was irresistible and everyone wanted her. Hallucination. So heard a voice, which means auditory hallucination. When she speaks, she cannot focus on one topic at a time. Her mood is euphoric. Her affect is labile. Affect labile means like easily distractible. So what is this thing going on? Cannot focus on one topic at a time, which is flight of ideas, euphoria, affect labile. That's mania, right? So you have got mania in a patient as well as psychosis in a patient. She recounts an episode last year where, although she did not have an elevated or depressed mood, she heard voices she could not describe. So she had another psychotic episode, only psychotic episodes 1 year ago. And that symptom lasted more than 6 months and caused her lose her job. So schizoaffective disorder, the symptom will be when a patient has both bipolar disorder features with features of schizophrenia, and on the top of that there is a history of delusion or hallucination for at least 2 weeks in the absence of any mood symptoms. So what does it mean? Our patient has schizophrenia, our patient has mania. So that means it fulfills these two criteria. The last criteria, that in the absence of any mood symptom, patient should have some delusion or hallucination. Our patient says that 1 year ago, she was hearing some voices. That's the hallucination she had. But at that time, she did not have any other mood symptoms. So that's called schizoaffective disorder. Mainly, you should remember when a patient had both psychosis and mania or depression together, that's your schizoaffective disorder. Now, which one is worst? Schizophrenia alone or schizoaffective? Remember, schizoaffective has better prognosis than schizophrenia. Now, if this patient has active hallucination or delusion, that patient needs to be hospitalized. And then you can start with antidepressant medication first. If that is not effective, then consider adding antipsychotic. All right. Antidepressant only if the patient has depression feature. What if this patient will need antipsychotic first because she is having mania and psychosis. So best will be starting with antipsychotic. Clear everyone? This is a little confusing for many candidates. I guess after this class, it should be fine for you. Okay, now the next one related to schizophrenia is delusional disorder. Delusional disorder, I said to you a couple of minutes ago that when a patient has only delusion but no other features of psychosis, we cannot diagnose it as a psychosis, rather it will be delusional disorder. Now the delusion can be bizarre, can be non-bizarre. What is bizarre delusion? Bizarre delusion means that abnormal belief which is really unrealistic. Like if I feel like I don't have any head, if I feel that my soul is outside of my body, these are unrealistic and impossible things. That those are bizarre belief, and bizarre belief is a feature of schizophrenia. Some of the abnormal belief, like I think that one of the actress like me, okay, or I feel that I can be a president, or I think that I have cancer. These can happen, right? Even though having me as a president is very unlikely, but it's still like that. It's not totally unbizarre or non-bizarre. So non-bizarre delusion is like kind of which is not totally unrealistic, and that's usually the features of delusional disorder. And another feature of delusional disorder is that it doesn't affect patient's familial occupational life. So patient will be totally fine. Only that particular abnormal belief will be there. So you see in here, Mr. Smith has been married for 10 years. During most of those years, he believed his wife was trying to poison him to get his money. So this is a kind of delusion or abnormal belief. Now this one is bizarre or non-bizarre. It can happen. It's not like it cannot happen. So it's non-bizarre. And do you know like what is this type of delusion called? This is called persecutory delusion. When a patient feels or believes that someone is trying to harm or spying on them, that's called persecutory delusion or paranoid delusion. He frequently complains of stomach pain, which he believes is due to the poison in the food. His thoughts are logical and coherent, so there is no thought disorder. He denies any hallucination. His wife, an independently wealthy woman, doesn't understand her husband's logic because she has more money than he does. Okay, so delusional disorder should be kind of like this. Say, just this patient is only having one particular abnormal belief, doesn't have any abnormal thoughts, no, his thought content, thought are logical, everything is good. So that's delusional disorder. The symptoms will be non-bizarre delusion for at least 1 month, no impairment in the level of functioning, very important to find this in the question. The patients are usually reliable. Okay, so that's mainly the presenting feature. This sort of patient doesn't need to be admitted. Outpatient treatment is usually preferred. And usually you can give some antipsychotic medication. Now, this question is related to what we discussed. Tell me what is the diagnosis in this question. 37-year-old woman brought to the ED by police after she was found trespassing on a famous film actor's estate. The patient is excited and says that this is all a big misunderstanding. She explained that she was only trying to leave the actor a surprise gift and a note and would never harm him. She recently received a signed photograph in response to one of her letters and keeps it in a box filled with newspaper and magazine articles about that actor. Patient says, for now, we need to keep our relationship secret. Although she hasn't met the actor in person, she is convinced that they will be together someday. Patient has worked for many years as an administrative assistant, no difficulty performing her job, keeps to herself as she feels that her coworkers do not understand. She is calm and cooperative. Speech is good. Mood is wonderful because I am in love. Which of the following is the most likely diagnosis? So this patient, if you see, now this patient is not having mania, because if it is a mania, it should be like it should affect the patient's work life, family life, all things. And this patient's not having any other features apart from just some, I would say like this is kind of grandiose behavior, grandiosity, I can say. Borderline personality disorder is patient usually has irritable, angry, and like frequent mood changes and features of harming herself. So it's not here. Narcissistic personality disorder, patient usually will be very bossy and self-boosted and always want to be a center of attention, not in this case. Schizoid personality disorder, these patients usually are very isolated, is not interested in anyone else, okay, always keeps himself within a place so that no one interacts. So that's schizoid. And schizophrenia, this patient doesn't have hallucination, no other thought disorder, so unlikely. So our diagnosis should be delusional disorder. Clear? Good. You guys are doing great. So I guess you understand that. Now, another question. Let's solve this one as well. 74-year-old man is hospitalized due to severe depression. A 9-kilo weight loss over the past month. Family members report that he has become progressively withdrawn from friends and family, stopped attending his weekly game, refused to leave the house. She sleeps poorly. The patient has a history of depression. A recent trial of SSRI was ineffective. History of hypertension, MI. In the hospital, efforts to get him to eat are unsuccessful and he barely drinks. On mental status examination, patient's eyes are downcast. He gives brief, barely audible response, reluctantly discloses that he has been hearing the voices of his brother. What is the most appropriate treatment? So tell me what you think. This patient is having severe depression. Now, patient hearing the voices, which is psychosis, worst prognosis, and most important that he's not eating and drinking. So for this particular patient, what you should do, you want to try antipsychotic medication, cognitive behavioral therapy, ECT, MAO inhibitor, SNRI, TCA. So as I said initially, remember this, if a patient has severe depression and it's a geriatric patient, 74-year-old, like old elderly patient, on the top of that patient is not eating and drinking at all, that patient has an urgent indication for ECT. Okay, on the top of that, patient is having psychosis. So main indication for ECT is that if a patient is elderly patient, not eating and drinking, having severe depression. Also, if a patient having depression with psychotic features. Depression with psychotic features, you will not jump to ECT. You will try adding antipsychotic first, then go for ECT. But in this patient, as the patient is not eating and drinking, this patient needs urgent ECT. Now, next question. If you want to give ECT to a patient, whose consent will be needed? Can you give a patient ECT without their consent? So let me say first thing that you have to ask for a consent from the patient. But most of the time you will be unable to do that because this patient will be severely depressed and having psychosis. So they have loss of insight. So they are inside, they don't have any insight, their consent doesn't work. No immediate family can give consent for ECT. No, like this is the only part when you cannot take consent from patient, you have to go for tribunal. Okay, even like two psychiatry doctors, whatever it is, but mental health tribunal should pass ECT, otherwise never ever. Now, so obviously before doing a ECT you have to go for mental health tribunal. Now there is an exception. If a patient becomes severely dehydrated, that there is a chance of life-threatening situation, that time you even don't need mental health tribunal permission, you can go for ECT. So the question should say that patient is stop eating and drinking at all, and patient is severely dehydrated. That time you even don't need mental health tribunal permission because you are acting on behalf of the best interest of the patient, and that's permitted. Clear? These are very important questions. Yes, under duty of care. So that was mainly our today's session on depression and on psychiatry, mainly schizophrenia, bipolar disorder. I hope this class was helpful for you guys. Now, before we finish the session, I just want to talk with you for another 5 minutes time, just to know that how everyone's preparation is and what you expect from a course. And if you have any questions about our next available course, which is starting from 31st of October, and that will be a 5 months course, as you understand. And before that 31st October, we are going to take a 2 weeks free session with you guys, covering a lot of other queries. We will cover some of the recent questions. We'll try to solve those, and we'll try to do some more theory classes with you guys. We'll try to do a cardiology session because cardiology is very important for you. And let me show you our course structure. I want you to be sure before you before you want to join a course, you should be totally sure that what you are doing, it is worthy of doing. Let me just give me a time. So this is our course details. Sorry, just to stop here, because this is the important thing that you should know about the course. So these are the course contents that you guys are looking for in here. So we'll do the full theory sessions with you, covering all the topics that we need for your exam, which will be like medicine, surgery, psyche, all the things. We take theory-based mock exam for you guys, which means that after doing 3 psychiatry sessions, we will do some psychiatric question solvation, and after that you will take a theory based mock exam, which will be software based, which means that you need to appear for a psychiatry mock exam, just like after cardiology another cardiology exam, after respiratory exam. So in that way, all the theory based mock exam you have to appear in our software. We covered 2 years recent sample questions. Usually we are still uploading those questions in our software. We haven't done it totally at the moment, but every day we are updating our software, and it's enriching with thousands and thousands of questions which are solved. We also take sample questions, unlimited mock exam, which means that we have a lot of mock exam for these monthly questions. We have a Q bank, which you will get free of charge. And we have the software, which is, I will show you how our software works after this video. I think that it should be a very, very good resource for your MCQ preparation. And all the classes that we do, all are fully recorded. And you get lifelong access to all our lecture materials, particularly the notes. Let's see the others. Thank you everyone for listening this one. I don't have any 3 months course. I'm really sorry for that. And we don't have any recall solving session only. We always do the theory and the questions together. This is the only session we have. Sorry for that. And the next one, like I want you to see how what are the research you guys are going to get. So once you go into our software, you should be able to get a lot of important things. Like if you go into our MCQ theory notes, you will find out all the theory notes or the lecture notes will be here. Like if I open just one, let's see. So if we open this one, rheumatology, so you can easily read our lecture note from here. So all the lecture notes will be uploaded in our software. So it will be lifelong access for all of you. You can easily read anytime you want from anywhere. Then there are lots of sample questions. So you see that we have March question, July, all the monthly questions we have here. Together with that, we have like surgery questions, like theory-based questions are also uploaded here so that you can easily go through all these questions. If we open the pediatrics, sometimes it can be a little slow because these are very big file. So if we go into that, the respiratory medicine, we have all the questions. Okay, so we can easily find out the questions answer in here, and you can obviously revise that. We have like all the questions we upload here, and then you'll be easily finding out the answers and also related materials to understand those. Okay, and then sometimes we have a lot of available MCQ tests for you already. So you can easily start appearing our monthly exam, our theory exam, our grand mock test exam. So all those exams are here for you. You can easily find it out. And the good thing is that you can find your MCQ results after appearing these exams immediately. And you can see how much percentage you have got, if you passed or failed. So you can find it anytime. So it's a very important and good resource, and very, I would say, like if you can follow our course totally for a 5 months time, you should take at least 1 or 2 months for revision, and then you'll be like easily should pass this exam without any problem. Was there any problem with the sound quality? I don't understand. Who asks about that? Dr. Jubair. No, it's not like I'm not only JM based. We follow JM, we follow Kaplan, Step 2 CK, and we follow also other books which is important. Not like we don't need to follow T genre for surgery. I don't think it's very important. We follow the books which is important for your exam, and mainly we follow a lot of websites. Like we have RACGP website for your medicine, we have RCH website for your pediatrics, we have RCOG website for your obs-gynae, range CP for your psychiatry. So there is a lot of website that will help you much more better way than a book. Even JM sometimes may not like answer your queries. So sometimes we have to go into those websites. Yes, once you join, you will be able to access all the mocks and software. So there is no restriction on using that. It's all uploaded. You can easily appear exam anytime you want. It's not like you have to appear in a given time. You can appear when you finish your study. It's according to your own pace. Okay, and it will be there as long as you pass the exam. Yes, as I said, the classes also will be recorded in the software. I haven't shown it to you. Same, the videos are also recorded in the software, so you will get it in the software. No, you don't need to find the answers of MCQs by yourself. We will try to finish or solve your queries, but sometimes like there are like thousands and thousands of MCQs. Sometimes we may miss some, but if you ask us in the class or in our group, we will try to solve it for you. Any question for those who are in our Facebook? Recording will be available, Dr. Sidra Jawad and Dr. Kolma. Yeah, I hope you passed the exam. I hope this session was helpful for you. I understand that this session is not like very important for you because you should already know all these things. But if you pass the exam, obviously come to us. We will show you the next step. We have a very good clinical course and people are loving that. So I hope that you pass your MCQ and then we'll be able to show you the correct path. If you want to register for our course, then go to our website and also you can email us to our email address. All those information are given in our group First Aid AMC MCQ. So you can easily find our website address. You can find our email address. Now, if you cannot find anything, find the admin and send him a message. Obviously, someone will be there to answer your queries. You don't have any class tomorrow. Tomorrow is there is no MCQ class. Your next MCQ session will be on 15th October. We'll try to do some question solvation at that class. I will upload all the class schedule for this 2 weeks free session. If anyone wants to join, you are okay to join. There is no fee for that. And I'm sorry, we don't offer any installment because it's a very minimum amount and it causes some problem with like keeping up all the things. So we don't actually offer installment for MCQ, but we offer for clinical. Any question? And if you want to go for registration of our course, what you have to do is, let me show it to you so that you guys understand. So you go to firstaidamc.com. Once you go into the firstaidamc.com, this website should come up. And then you just need to, in here, because I'm already logged in, so they haven't shown me any login button, but in here, you should find a login or subscribe button if you are already not subscribed. So just go to the subscribe button. Once you go to the subscribe button, they will ask your information. They will ask for some of your identities to make sure you are a MCQ candidate. And then there will be a payment option. So once you do all these three things, then you'll be added to our course. Okay. The free trial class is for 2 weeks. So it's not like we are offering 2 weeks free session to understand what our course is. Like there will be a lot of courses available who will give you one trial class, and then that trial class will be very good and you will join that class or course, and then you will find out that that course is not that much helpful for you. So that's why we offer you a 2 week session to see how is our course, how is our teaching. Then you should make an informed decision. Okay, this is for your own benefit, and then you will be able to understand that if this course is helpful for you or not. We'll upload the trial class schedule tonight. I don't know actually the amount in USA dollar because we don't use USA dollar in here, but I think you can convert it. That should be fine. No, it's Dr. Maria, it's just our class 1 for psychiatry. There are 2 classes that we take in our course. Normally, for psychiatry, we need at least 3 classes. And our email address, I'm just writing to you in the chat box. It's firstaidamc4536@outlook.com. All right, you can like email us for any inquiries you are having. Now, Dr. Manal, as our online course is just started the last, in the beginning of this year, not in the beginning. So we just had one batch, which we are still continuing. So they haven't appeared our exam yet. So we'll see in the November that how many students passing from our course. And do you create a MCQ question solving group? Yes, we usually we ask someone from the course usually to create a question solving group, and then we add the people who are interested to do the question solving in that group. We are based in Australia. We are Sydney based. All right. So if you have any questions regarding the course, feel free to ask it. Okay. And yeah, that should be fine. Thank you so much for joining our session. We will meet again in this 2 week session, I guess. So if you have any other questions, feel free to ask me that time. Thank you, everyone. Have a good night. Bye.